This programming is brought to you by Boehringer Ingelheim Pharmaceuticals Incorporated. Heart failure guideline-directed medical therapy offers an opportunity to provide better care for patients, but significant gaps in uptake remain. Now more than ever, it's time to pump up GDMT for heart failure. Leaders in the cardiology community recognize this need and are asking you to do the same. Visit pumpupgdmt.com to learn more. Together, we can help ensure guidelines are enacted and patients receive quality care.
Zoll LifeVest is a proud sponsor of CardioNerds. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Hello, CardioNerds. Dan Ambinder here, and we are back for an amazing CNCR learning session. We're at Tufts Medical Center, and we're with three great people. Rachel Goodman, who is our current CardioNerds Academy Fellow, and she is in the House Jones, special house, of course, and she's going to be the incoming chief for next year's CardioNerds Academy class, and she's joined by Munim Khan and Shravani Gangidi, all fellows at Tufts Medical Center. Team, welcome. And before we introduce them, let me introduce our guest host tonight, and that is going to be Dr. Yoav Karpenshif, who's an assistant professor of clinical medicine and critical care and a master whiz at critical care cardiology at University of Pennsylvania. So for our dedicated listeners, you'll know Yoav from a variety of episodes and projects. Yoav, thank you so much for hosting, and I'm so excited for you to lead this episode.
Thank you, Dan. Thanks for that kind introduction, and I'm so excited to be here. And I'm so excited for this case. Once again, Rachel, Shravani, and Munim, how about you introduce yourselves?
So my name is Rachel. I'm a current first-year cardiology fellow at Tufts with an interest in heart failure and critical care cardiology.
My name is Shravani. I'm a second-year cardiology fellow at Tufts, the rising chief fellow for next year and interested in EP.
Hi, everyone. My name is Munim Khan. I am the current chief fellow at Tufts, and I'll be passing on the baton to Shravani fairly shortly as I move on to the world of electrophysiology, as I'll be staying on at Tufts for my EP fellowship.
I'm so glad that you guys are here, and tell us, where are we going for this talk about a really interesting case in cardiology?
So Yoav, Tufts is in Chinatown, and we spend a lot of time there after work. So we're going to go into Chinatown for some hot pot.
That sounds amazing.
What exactly is hot pot?
Hot pot is maybe the best thing ever. It is like a table with a pot of the soup in the middle, like a broth, and you can choose what kind, and then you cook food in it. So all types of veggies and tofu and meat and fish, and you kind of cook it yourself, and then you eat it, and it's amazing. And I highly recommend it.
Oh my gosh, that sounds delicious. All right, well, let's eat this hot pot and get rolling. Why don't you tell us about a case in cardiology?
So this is an average day at Tufts, where we get an email about an incoming transfer to our cardiology service. What we know so far is that there's a woman in her 30s being transferred for cardiogenic shock, with further details unknown. Upon arrival, she tells us that for the past few weeks, she's been having episodes of palpitations and breathlessness with profound orthopnea and paroxysmal nocturnal dyspnea. She was recently evaluated for this as an outpatient and diagnosed with panic attacks, for which she was given an as-needed benzodiazepine. However, she continued to have symptoms and ultimately presented to urgent care with chest pain.
Shravani, thank you. I think many of us know where this story is going. We are CardioNerds after all. But I do want to take a quick pause and reflect on this situation, which is all too common. Young women, really women and minority of all ages, with cardiovascular symptoms being chalked up to anxiety or panic attacks. This is no way to fault our healthcare team here, but more so to highlight that this is a problem and should be a diagnosis of exclusion.
Yeah, totally agree with that, Munim. And upon arrival to the emergency department at Tufts, her initial vitals showed that her heart rate was 125 beats per minute. Her systolic blood pressure was in the 60s. She was given isotonic fluid for this. Her initial lab work showed a serum creatinine of 1.1. Liver enzymes were within normal limits. Her lactate was 4.6. And her high sensitivity troponin was 1,086. She had a negative viral panel. Her CT-PE did not demonstrate a pulmonary embolus, but did demonstrate bilateral ground glass opacities, which were concerning for pulmonary edema. Her echocardiogram on arrival showed a left ventricular ejection fraction of 20%, with hypokinesis from the base to the mid left ventricle in all the walls, with normal right ventricular size and function. She was admitted to the ICU at the outside hospital. Milrinone was started prior to her presenting to the emergency room here.
Okay, a lot has happened already. But before we talk about the rest of her course, I'm hoping to get your thoughts about her echo. I'm a little bit confused. So, the pattern of hypokinesis is interesting. It doesn't really fit with a coronary territory, but it seems to be the exact opposite of what we generally see with takotsubo. I'm kind of wondering what you think.
That's a really good observation, Rachel. It is an interesting pattern. Her apical wall motion was preserved, but there was basal to mid left ventricular hypokinesis. Like you said, this doesn't fit with the clear coronary distribution, but given the troponin elevation and her symptoms of chest pain, however, I do think a left heart cath is warranted here. In the meantime, keep this echo pattern in mind. We will come back to this.
Okay, so just kind of continuing off from where Shravani left off with the need for a left heart cath, to mention when we had received the patient, she did have an impella in place, but kind of backtracking the story a little bit to what happened at the outside hospital. Just based on her initial presentation, she did undergo a right heart cath and a left heart cath at the outside hospital. This left heart cath did show normal coronaries. We don't have her right heart cath numbers because, as I mentioned, this was done at an outside hospital. But based on the numbers there, the team felt that an Impella CP left ventricular assist device was warranted, and this was placed based on the findings there. The hemodynamics that were noted just prior to admission while on P9, which I should mention here is the maximal setting of the Impella CP, and the P level is basically a setting that's used for rotational speed. On P9, the patient showed the following hemodynamics. The RA was 22, P systolic was 49, with a PA diastolic of 21. Wedge pressure was 34, with a FIC cardiac output of 3.3 and a FIC cardiac index of 1.5. As mentioned, she was at the Oxford Hospital at this time, and despite maximal support on Impella CP on P9, she remained hypotensive, and so she was sent to Tufts for further consideration of higher level of support.
From what I'm hearing so far, we have a young woman with de novo cardiogenic shock from non-ischemic etiology, now requiring mechanical circulatory support. And despite being on maximal settings of her percutaneous LVAD, she's still not doing really well with very low cardiac index and biventricular elevated filling pressures. So it sounds like she's going to the right place for you. And how do you think about patients with this?
So I think, as you mentioned, when thinking about her right heart cath numbers, we have evidence of elevated biventricular filling pressures, a depressed output and index, and then she has evidence of hypoperfusion with an elevated lactate. Shravani, how would you classify her overall shock phenotype?
So at this point, I think, she's persistently hypotensive. She has evidence of hypoperfusion despite an Impella CP and while being on inotropic support. So she would classify as a Sky stage D shock. She's not quite stage E. In that subgroup, you would need to have worsening hypoperfusion with the lactate greater than 10, a pH less than 7.2, or increased treatment intensity requiring more than 3 drugs or devices.
Shravani and Rachel, thank you so much. Now, going back to the story and sort of fast tracking, now the patient has arrived at Tufts in Boston in the heart of Chinatown. Upon arrival to our CCU, she was noted to have dark urine with minimal urine output overall. At this point, since she had just arrived, we had no labs back yet, but given the concern for hemolysis based on the urine, her Impella CP was empirically dropped from P9, which I mentioned earlier was the max setting for the Impella CP, down to P7. At this time, since we had decreased her Impella speed, we actually added on dobutamine 5 at this time in addition to milbrenol. So this patient at this point is on dual inotropes, so dobutamine at 5 and milbrenol, and now is on Impella on a P7 setting.
Okay, let's talk about hemolysis with mechanical circulatory support for a minute. Rachel, can you talk us through what's happening here?
Of course. So with an impella, you get hemolysis essentially from mechanical stress on your red blood cells. This can happen for many reasons. Some of them can be improper position, others can be clot entrainment, and then your P level can also impact things. So when these patients have an impella and they're in the unit, we check for markers of hemolysis multiple times a day. So things that we learned in residency. So high LDH, low hapto, elevated plasma-free hemoglobin, low hemoglobin, elevated creatinine, and an indirect hyperbilirubinemia. If you check a UA, you'll see your classic heme positive, red blood cell negative pattern, and you may also have dark urine. When you have evidence of hemolysis, you should look for two things pretty quickly. The first is position, and doing a quick bedside echo can help you with this. The next is your P level. So, as you heard in this patient, we dropped the P level fairly quickly and saw a pretty quick improvement in the color of her urine, and her LDH also went down. I think it's worth noting that oftentimes when you drop the P level, so you're essentially dropping your RPMs, which means you're decreasing the amount of support that you're getting from the impella. Doing this often requires an increase or initiation of an inotrope to compensate for the decrease in support from the impella. So with this patient, we dropped her from P9 to P7 and also put dobutamine on at the same time. The only other thing to note about hemolysis here is that patients often need blood if they have hemolysis to the point that they have a decrease in their hemoglobin.
Rachel, what an incredible overview of hemolysis with these devices. And this can be a true emergency. This patient was sent to your center for a consideration of advanced therapies. And as we know, hemolysis can be pretty toxic to the kidneys. And without kidneys, advanced therapies become harder and harder. And so I really love your approach and thinking about it. And the two things that you mentioned, which I'm just going to highlight again, is understand where the impella is and then change what you can to try to minimize hemolysis when it's happening. So reducing the speed. One thing, if you have a ultrasound in your hand and you're trying to remember how deep an impella should be, a relatively good mnemonic is to first ask what device you have. And so the Impella 5.5 flows 5.5 liters and should be 5.5 centimeters from the aortic annulus. In the Impella CP, it flows 3.5 liters and it should be 3.5 centimeters. So the CP should be shallower in the ventricle than the Impella 5.5. Just something I usually teach my fellows, and hopefully something that can be helpful and help patients like this.
Rachel and Yoav, thank you so much for giving us this overview of hemolysis. I will take everyone back to Tufts now to get back to our case. So the patient did settle in to our CCU after arrival, but her hemodynamics remained marginal. Going through some of her data, her vital signs showed sinus tachycardia with the heart rates running from 130s to 140s. At this point, her MAP was as high as 94. She was breathing really high in the 30s, so fairly tachypnic, with an oxygen saturation of 94% on 6 liters of oxygen. Her blood gas showed a pH of 7.42, PCO2 of 30, and PO2 of 66. At this point, with her Swan plates, her right heart cath numbers were as follows. Her RA pressure was now 5, PA systolic was 36, with a PA diastolic of 20. Her cardiac output was 5.7 with an index of 2.6. Again, just to highlight, at this point, the patient was on dual inotropic support with milrinone and dobutamine, and also Impella CP, at this point on P7. Given her ongoing dyspnea and her tachypnea and increased work of breathing, she was intubated. After intubation, there was a recheck on her hemodynamics, but there was minimal to no change. And ultimately, there was a discussion regarding upgrading her support. Now, Yoav, thank you for that really helpful mnemonic regarding the placement distance for the Impella 5.5 and the Impella CP, because at this point, we decided to upgrade the patient from an Impella CP to an Impella 5.5 with the hopes that she would be better supported. Just to reemphasize the flows through the Impellas, the Impella CP runs flows somewhere between 3.7 to 4.3 liters per minute, whereas the Impella 5.5 is somewhere between 5.5 to 6 liters per minute. So again, we do have more flow that can go through the Impella 5.5. Her Impella 5.5 implant was relatively uncomplicated. However, after she did develop some intraprocedural vasodilatory shock, which was likely secondary to sedation. When she arrived back in the CCU from the cath lab, her Impella 5.5 was set at P6. To compare her urine to prior, at this point, the urine remained clear, and her LDH was trended on labs and continued to downtrend. Just to mention here, her hemodynamics with the Impella 5.5 in place. Her RA pressure was 10, PA systolic was now down to 19, PA diastolic was 11. We were unable to get a wedge pressure for the patient at this time in the CCU. Our cardiac output was up to 8, and our cardiac index was 3.2. I had mentioned earlier that our hemodynamics were on the Impella CP and dobutamine plus milrinone. This set of numbers that I just mentioned were taken on some norepinephrine, some vasopressin, dual inotropes with dobutamine and milrinone, and the Impella 5.5 at P6. At this time, we were also giving her some spot doses of Lasix.
Okay, so where are we? Can you share a problem representation, Shravani?
Sure. So we have a young woman with de novo Sky stage D heart failure cardiogenic shock. This is non-ischemic cardiomyopathy. Her initial presentation and hemodynamics were suggestive of biventricular congestion, though now on support with dual idotropes and mechanical support with an Impella 5.5, this appears to now be a predominant LV dysfunction pattern.
Awesome. What about etiology?
So, in terms of etiology of her cardiogenic shock, we had initially considered immunosuppression. However, based on history and the fact that she was electrically quiet, this was deferred. There was discussion of myocarditis versus stress cardiomyopathy, and the need for endomyocardial biopsy was discussed. And ultimately, this was deferred given hemodynamic and echocardiographic evidence of improvement. Mechanical support was hopefully a bridge to recovery, and we had discussed that if there was no improvement or sign of recovery in the next 24 to 48 hours while continuing her on Impella 5.5 support, we would likely initiate an advanced therapies evaluation.
Shravani, thank you for that. I'm going to take us back to her case now. So her hemodynamics while on dual inotropes and Impella 5.5 support continued to improve, and she was extubated the following day. Unfortunately, later that night, she started to have worsening of her respiratory status again. Despite being on high flow set at 50% FiO2 and 40 liters, her oxygen saturation was in the low 80s. And even with prompting and having her, take deep breaths through her nose, this oxygen saturation would not return to 90%. Sort of as a last-ditch effort to avoid reintubation, we did decide to try Narcan on her as she had been on the dilaudid drip prior to extubation. With Narcan administration, she did wake up and was more interactive, but continued to note difficulty breathing, and her oxygen saturation was not coming up to 90%. At this point, the decision was made to reintubate the patient. Despite intubation, however, it was difficult to maintain her oxygen saturation at greater than 90%. Some ventilator changes were made. Her PEEP was increased to 10, and she was placed in reverse Trendelenburg position in an attempt to mitigate abdominal pressures, pushing up into the thorax. We, of course, made sure that the ET2 placement was appropriate on imaging, and when getting the imaging, noted that she did have some right lower lobe atelectasis. Given this acute decompensation in her respiratory status, a bronch was then performed at bedside, which was helpful in removing some fresh bloody clot and some secretions from the right upper lobe, right middle lobe, and right lower lobe. With all that happened here, the ultimate thought was that her hypoventilation, her obesity, and her somnolence all contributed to some right lower lobe atelectasis, which led to hypoxemia. At this point, we put her on some Decadron for subglottal edema. So all this seemed to stabilize. However, the next day, her physical exam was notable for left-sided weakness that became evident when we tried to wean her sedation. A stroke code was called and stat imaging was obtained. However, the CT scans were negative. An MRI could not be obtained due to the Impella. Around the same time as this sudden focal deficit in her motor function, her Impella started to have some low flow alarms. Her blood pressure was at goal on nitroprusside, and the right ventricle looked okay and unchanged on both the echo and also verified and validated by our hemodynamics. Given concern for a cardioembolic stroke related to the Impella, with some thrombus that may have dislodged, and resulting in some low flow alarms due to that thrombus, the impella was subsequently removed in the cath lab. Unfortunately, of course, it get a little complicated after this, as she did have flash pulmonary edema at the time of impella removal. So she actually had to have an emergent axillary intra-aortic balloon pump placed for some mechanical support. We did do our due diligence and look at the impella following removal and saw notable clots throughout. After this, she was extubated the following day with the intra-aortic balloon pump in place, however, continued to have left upper extremity weakness. Given ongoing concern for a stroke, a head CT was repeated at this time and did show a right caudate and lentiform nucleus infarct.
Munim, that's devastating. Is there anything about the impella that led to the stroke? Or do you think it was all just kind of a fluke and it happened at the same time?
That's a great question, Rachel. Patients with an Impella device are prone to thrombus formation. There is, after all, a foreign device, sitting in their left ventricular cavity. These patients are generally on systemic dose of anticoagulation in order to prevent thrombus from forming along the body of the device. In her case, she was on a heparin drip. Despite this, patients can form thrombus, especially in the setting of hemolysis. And as with any thrombus formation in the left ventricle, there's always a risk for stroke. So this is something, that we frequently assess in the CCU with daily spontaneous awakening trials and serial neuro exams.
What about the purge heparin? Does that help at all?
The goal of the purge solution is actually slightly different than what you would expect. It's to prevent blood from entering the motor housing unit. Heparin or sodium bicarb solutions are usually preferred. The purge fluid runs in the opposite direction of blood flow and essentially creates a pressure barrier, decreasing the chance that blood comes into contact with two specific areas, which is a gap between the motor and the rotor and a gap between sleeve bearing and the back of the impeller. And we want to avoid this contact because blood can get broken down in the motor, which carries a risk of its degradation products depositing around the screw, which is the actual impeller, which will lead to increased resistance of the impeller. And as you can imagine, with more resistance, it's harder for the screw to spin. If there's clot entrainment or contact between blood and the motor system, you might notice a sharp increase in motor current. The motor current is a measure of how much energy the motor is using. It's usually measured in milliamp. And we can delve into motor current and its importance another time. It's very interesting. But for our purposes now, I just want to highlight the potential change in current with clot ingestion. Essentially, if the screw is facing a higher resistance from clot, it's harder for it to spin. And the motor will need to use a higher current to ensure that flow is adequate at a given P level. This can be scary because every P level has a predefined current that, if it reaches the maximum current, can cause the pump to automatically turn off.
So, correct me if I'm wrong, but it sounds like you're saying that we should think about clot entrainment when we see a constant P level with increases in motor current. Is that correct?
That's correct. Another thing to think about, clot is a sudden decrease in flows despite an unchanged P level, which is what we saw here.
Okay, so there's a lot. Let's get back to our case. Munim, how did she do?
Rachel, I love giving good news. So despite this setback, she ultimately did quite well. She was extubated, the balloon pump was removed, and after transfer to the floor, she was discharged to rehab. We did see her the recent follow-up appointment, and she was doing well, and her LVEF had actually gone back to normal. The conclusion at this time that we had was that she had stress cardiomyopathy related to cardiogenic shock.
What a case. I'm glad she got better, both from a cardiac and neuro standpoint. I think we should take a few minutes to kind of go back to her echo and talk about takotsubo overall and what we can learn. So, Shravani, what is takotsubo?
So takotsubo cardiomyopathy or stress cardiomyopathy, it was first described in 1990. It's a reversible heart failure syndrome that's characterized by impaired myocardial contractility and acute heart failure without evidence of epicardial coronary disease. But you do see regional wall motion abnormalities on echo that do not correspond to coronary territories. The reversibility is key here, and this is what distinguishes it from other etiologies of heart failure. And the syndrome is distinct from classic acute coronary syndrome that we think about, but can often present similarly with chest pain and elevated troponins. You may see ST elevations, or you might have an EKG that also may look non-ischemic. And patients who generally develop takotsubo, this is usually following an acute stressor, either emotional or physical. There's some literature that divides takotsubo into primary and secondary forms. The distinguishing feature here is why they presented to the hospital. If they presented because of the cardiac symptoms, the takotsubo cardiomyopathy is defined as primary. If they presented for another reason and then had a sudden stressor leading to a cardiomyopathy, this is defined as a secondary takotsubo or stress cardiomyopathy. In our case, our patient presented to the hospital due to chest pain, and with her clinical history, I think this would be defined as a primary takotsubo cardiomyopathy. An example of secondary stress cardiomyopathy would be if a patient presents to the hospital for cholecystectomy or some other surgical intervention and then develop a cardiomyopathy afterwards.
Who gets takotsubo?
There are some gender differences here, and takotsubo generally occurs in postmenopausal women. That said, anyone can develop a stress cardiomyopathy.
And what about the pathophys?
We'll get into the pathophys in a second, Rachel. One thing I do want to mention here is that takotsubo itself is a word that comes from the Japanese word takotsubo, which means octopus trap. And this is because the heart chamber looks similar to a takotsubo pot, which is a Japanese fishing pot used to catch octopus. So that's my fun fact for the day. Now, back to your question about pathophysiology, Rachel. Now, that is something that's not completely understood, but we can review what we do know. So we know that catecholamines are key here. There are reports that circulating levels of plasma catecholamines are up to 3 times higher in patients with takotsubo than those with acute MI and resulting heart failure. There are also reports of iatrogenic takotsubo following administration of epinephrine, dobutamine, beta agonists, all of which further support this theory. Further, there are reports of takotsubo in patients with pheochromocytoma, which, as we all know, is a high catecholamine state. Interestingly, there are preclinical models that show that administration of high-dose catecholamines can cause takotsubo. There are other supporting features of this catecholamine theory, but you get the point. They're likely implicated in the development of takotsubo.
So catecholamines are important here, but there are plenty of people with stress or other high catecholamine states who don't develop takotsubo. Why is that?
That's a great question, Rachel. And I guess we don't actually know. What we do know, however, is that, postmenopausal women have the highest incidence of takotsubo. There's some thought about the role of estrogen here, but the data is not really fully understood.
So let's move on to presentation. How do patients with takotsubo generally present?
In terms of presentation, these patients generally present similarly to ACS. They have chest pain, and lab draws often reveal elevated biomarkers. Some have non-specific EKG changes. The classic finding, though, in patients that have takotsubo cardiomyopathy is the pattern of wall motion abnormality seen on echocardiograms. There are different variants, which we will discuss, but it is important to note the presence of wall motion abnormalities that do not follow a coronary territory. Despite this, however, most patients with takotsubo syndrome should have a left heart cath to rule out epicardial disease, as takotsubo is a disease of exclusion.
So let's go back to the echo findings. Can we talk about them a little bit?
Sure, Rachel. We already discussed this patient had the presence of wall motion abnormalities that didn't correspond to a coronary territory. And, these wall motion abnormalities are transient and can generally improve with time, often over days, but generally can be up to a few months as well. There are different variants of takotsubo cardiomyopathy. Each can have a different anatomical pattern. The most common variation is one with apical ballooning that Munim had mentioned earlier. And patients with this variation have hypokinesis or akinesis of the apical and mid left ventricular segments with basal hyperkinesis. This is the most common variant, usually occurs in about 50 to 80% of cases. It is important to note here, however, there are other variants. There is a mid ventricular ballooning variant in which your mid ventricular segments are preserved, but your basal and apical segments are hypokinetic or akinetic. Even more rare is what our patient had, which is the basal variant takotsubo, also called inverted takotsubo, in which the basal segments are hypokinetic and the apical segments are hyperkinetic. and this variant is sometimes referred to as artichoke heart. There are also biventricular variants and isolated right ventricular variants, though these are way more rare than the presentation that our patient had. And interestingly, patients with recurrent takotsubo do not necessarily have to have the recurrence of the same anatomic variant.
I love talking about echo. Do we know why people develop these echo findings, Munim? They're quite unique.
That's a great question, Rachel. So, not exactly. There are some hypotheses as to why, however. So, there are two general buckets here, the vascular reasons and myocardial reasons. These can occur in isolation or happen together. The vascular hypothesis is that there is coronary vasospasm, potentially an aborted MI with recanalization and an acute rise of LV afterload. On the other hand, the myocardial hypothesis is related to catecholamine-mediated stunning of the myocardium. It is important to note, however, that these are very much hypotheses. And Shravani, at this point, I'd like to mention that I had no clue that this variant was called artichoke heart, but I'm all for it.
So I have a hypothetical case, Munim. Let's imagine that a patient presents with chest pain and a mild troponin elevation with a flat delta and has no EKG changes. The patient gets an echo, and the echo shows your classic apical ballooning variant. What do I do next?
That's a great question, Rachel. Most patients do have urgent coronary angiography to exclude ACS, given the overlapping symptoms and the idea that takotsubo is a diagnosis of exclusion. However, like we've alluded to, there are generally normal epicardial coronary arteries. It is important to note, however, that some patients may have background CAD. Classically, however, there is no evidence of acute plaque rupture, and the wall motion abnormalities on echo are out of proportion to the degree of CAD and anatomically not explained by the CAD.
So, with this in mind, if we go back to this imaginary patient and we're thinking they have takotsubo, given the pattern of wall motion on echo and the lack of epicardial CAD, is there any role for other imaging modalities here?
So, great question, Rachel. Let's talk about cardiac MRI here. Cardiac MRI can be helpful here for two main reasons. One is if there's concern for right ventricular involvement. MRI provides a more complete assessment of the right ventricle when compared to echo. Can also provide a more thorough assessment for left ventricular thrombus than echo can. And patients with takotsubo are at higher risk for LV thrombus if there's apical akinesis. Cardiac MRI is also helpful at distinguishing takotsubo from acute MI or myocarditis. Usually in the acute phase of takotsubo, T2 weighted images will classically show high signal intensity in the myocardium of the left ventricle in a distribution that fits with the area of the wall motion abnormality. And this pattern is usually not seen with acute MI or myocarditis. The role of late gadolinium enhancement here, however, is somewhat controversial. And late gadolinium enhancement is generally absent in takotsubo, and that can actually help separate it from patients who've had MIs. However, there's some data to suggest that low-level LGE can be seen in the acute phase of takotsubo with complete resolution on follow-up cardiac MRI.
Thanks, Shravani. So, thankfully, after a complicated course, our patient ultimately did okay. But how do patients with takotsubo generally do?
In general, yes, given the reversibility of their systolic dysfunction. However, there are important complications of takotsubo to think about when taking care of these patients. Some of these complications can include acute heart failure, arrhythmias, LVOT obstruction, like we mentioned, LV thrombus, and cardiogenic shock. So let's start with some of these complications. Munim, do you want to take us through this?
Arrhythmias, you're speaking my language, Shravani. So right off the bat, let's talk about ventricular and atrial arrhythmias, both of which are seen in takotsubo cardiomyopathy. These do tend to occur early in the course, and there is data to suggest that takotsubo syndrome is associated with abnormalities in ventricular repolarization, and this can lead to prolonged QT intervals. And folks here that have these prolonged QT intervals are at a higher risk of arrhythmias in hospital complications and even future rehospitalization. So the EKG is a gold mine when we talk about getting some further hints about how this patient's course might be. In terms of acute heart failure, these patients often present with heart failure symptoms, which is the most common manifestation of the syndrome. As we discussed earlier, LV thrombus can occur given the apical akinesis or really any segment akinesis. Now moving on to LVOT obstruction. This is not seen as frequently, but patients with takotsubo syndrome that have apical akinesis and basal hyperkinesis can develop SAM and dynamic midventricular gradient or LVOT obstruction. This can be made worse with the use of inotropes, which is important to consider in the context of the next possible complication, cardiogenic shock. Now, talking about cardiogenic shock and takotsubo cardiomyopathy takes me back to, presenting a little bit of work that I did on takotsubo back in ASC in 2018. The poster next to mine actually was focusing on basal takotsubo, and a gentleman I spoke with there presented to me that folks that have basal variant takotsubo cardiomyopathy actually have a higher risk of developing cardiogenic shock compared to the apical variant. Now, cardiogenic shock in this patient population is generally due to acute LV systolic dysfunction, and patients that had takotsubo cardiomyopathy who develop cardiogenic shock have higher mortality than those who do not have cardiogenic shock.
What a whirlwind. Thank you for that review. Can you round this out for us? What are 4 major takeaways from this case?
So a couple things to take away. Takotsubo cardiomyopathy, it's characterized by reversible systolic dysfunction with wall motion abnormalities that do not follow a coronary territory, classically in the setting of an acute stressor. Number 2, it's a diagnosis of exclusion. Patients often undergo coronary angiography to rule out epicardial coronary artery disease, given an overlap in presentation and symptoms with acute MI.
Continuing on, there are multiple echocardiographic variants of takotsubo. Apical ballooning is the classic finding, but midventricular, basal, and biventricular variants exist as well. Our 4th takeaway is that patients with takotsubo cardiomyopathy generally recover, but there are important complications to be aware of, including arrhythmias, LVOT obstruction, and cardiogenic shock. And Rachel, I know you said there are 4 major takeaways from this case. I would say there are 5. The 5th being the fact that you can call basal takotsubo artichoke heart.
Most important takeaway by far.
What an incredible case. Thank you so much, Rachel, Shravani, and Munim, for taking us through this. This patient was so incredibly lucky to have you taking care of her. You took her from new onset cardiogenic shock through complications of 2 different mechanical support devices through critical illness to recovery. And so it just shows what really good cardiac and critical care can do. So I learned so much today, and I have a weird craving for artichokes. I don't know why.
And for me, it's actually calamari.
I'd like to get into some of that hot pot again. That was very delicious. Team, thank you so much. This was a really, really important case, a harrowing journey of a patient who hit your doors with cardiogenic shock. We got to celebrate your highs and kind of fear for the lows of this patient's course. And we're so glad that ultimately she is doing better. And, it's a case that really highlights that sometimes when you want to go all in to help save a patient, you got to use the tools that you have at your disposal. And sometimes those tools come along with complications. And just knowing how sick your patient was and knowing how much they had to benefit from the Impella, it definitely is something to think about, especially when we encounter complications. But the complications that you had in your case were detected and managed. And we are all just amazed at the support that you were able to show this woman and get her through one of the most traumatic times that I'm sure she's having in her life with her family. So thank you so much, team. This was just an excellent, excellent, excellent case presentation and also overview and takotsubo 101, 102, and 103 course. So thank you so much.
Hello, CardioNerds listeners. My name is Mike Faulx, and I am a professor of medicine at the Lerner College of Medicine at Case Western Reserve University. I'm also a general cardiologist at the Cleveland Clinic with an interest in cardiac critical care and with an academic and clinical interest in takotsubo syndrome. Thus, this case is right up my alley, and I am thrilled to be a part of today's discussion. Before I begin, I would like to thank Ahmed and Dan for inviting me to participate in this case discussion. I also want to acknowledge the excellent work of Drs. Goodman, Khan, and Gangidi for their excellent case presentation and patient care. So with that, let's get started. I really love this case because it's a bit of a challenge. Here you have a 30-year-old woman with bipolar disorder and practically no risk factors for cardiovascular disease, who presents with frank cardiogenic shock after a few weeks of palpitations. Right out of the gate, this case is unusual. On initial presentation, her differential diagnosis is fairly broad. Although we are not given a description of her presenting ECG, her shock state in the setting of profound LV systolic dysfunction with regional wall motion abnormalities practically mandates the exclusion of ischemic heart disease as soon as possible. In other words, as soon as you can safely get the patient to a catheterization lab. In my mind, her angiogram is going to steer us in one of three possible directions. One, she's going to have an occluded vessel, in which case PCI and standard STEMI management would be the norm. Two, you're going to find evidence of spontaneous coronary artery dissection, or SCAD, finding that would be on my radar screen simply given her age, which puts her in that demographic. Or three, you're going to find completely normal or unremarkable coronaries, and you're going to have to think about something else. Her angiogram is described as normal, thus eliminating STEMI and most likely SCAD. Although I would closely scrutinize those films for even subtle defects with a low threshold to use adjunctive imaging such as OCT or IVUS to exclude the diagnosis of SCAD. I say this for two reasons. One, because SCAD can rarely cause shock, and two, because SCAD and takotsubo syndrome can actually coexist. I've seen this personally, and there are also some authors who suggest that SCAD and takotsubo syndrome may actually exist on a spectrum, with a common pathophysiologic mechanism of intense catecholamine and neuropeptide release causing dysfunction, where age acts as the discriminator as to whether somebody presents with SCAD if they're younger versus takotsubo if they're older. It's tempting to implicate the presence or absence of estrogen in this observation. And although there's no conclusive evidence that estrogen plays such a role, I find that possibility intriguing, and there are active investigations looking into that. And given the normal angiogram, our differential diagnosis now narrows. Our diagnoses would include takotsubo syndrome versus some sort of toxic cardiomyopathy versus an acute inflammatory cardiomyopathy related to something like either COVID-19 or giant cell cardiomyopathy. Given this patient's lack of alcohol or illicit drug use, a toxic myopathy seems unlikely. Additionally, her lack of electrical instability or high-grade AV block makes giant cell myocarditis less likely, leaving us with takotsubo as our probable leading diagnosis. Were it not for the presence of her Impella device, I think a cardiac MRI could have been quite informative at this stage in her presentation. Classic findings for takotsubo syndrome on MRI include dense edema in the dyskinetic segments of the myocardium, some mild early gadolinium uptake, but most importantly, essentially no late gadolinium enhancement, a finding that really helps to distinguish takotsubo syndrome from other causes of cardiomyopathy such as ischemia or inflammation. So with takotsubo syndrome at the top of our differential, we need to reflect on just how unusual this presentation is. Most patients with takotsubo present with an ACS or STEMI picture, with ST segment elevation accompanied by a lack of reciprocal ST segment depression being a typical presenting ECG pattern. The lack of ST segment depression is something that really can help discriminate takotsubo syndrome from STEMI. Only about 5 to 10% of takotsubo patients will present with cardiogenic shock, although interestingly, these patients will account for up to 25% of early deaths related to takotsubo syndrome. The shock decision tree in takotsubo syndrome involves echocardiography and a high index of suspicion. What you're looking for is whether there's dynamic LVOT obstruction from mitral valve SAM. This most often occurs in patients who present with the apical ballooning variant where there is concurrently hyperkinesis of the basal LV segments. This pattern is present in over 80% of patients presenting with takotsubo syndrome. The reason for the apical ballooning is not entirely clear, but it may be due to the way that beta 1 and beta 2 receptors are situated across the mammalian heart and how these receptors couple with either stimulatory or inhibitory submembrane signaling proteins in response to high levels of epinephrine and norepinephrine. There are intriguing data using rat as models that can replicate the appearance of takotsubo syndrome in the presence of high levels of epinephrine and norepinephrine. And it's just intriguing that it fits so well with what we tend to see clinically. So if you're confronted with a patient with takotsubo syndrome and cardiogenic shock, then ruling out severe LVOT obstruction is important early in their management tree. If you find significant LVOT obstruction, then the management of shock is dramatically different than what you're used to doing. In these cases, volume resuscitation, beta blockers, and alpha agonists like phenylephrine can be beneficial, whereas other agents such as inotropes or vasodilators are generally to be avoided because they can exacerbate the problem. Our patient presented with a reverse takotsubo pattern, which is fairly rare, accounting for about 2% of takotsubo cases. There was no evidence for LV outflow tract obstruction, and so the management of this patient's shock is approached in a manner similar to other forms of cardiogenic shock, including the use of pressors, vasodilators, inotropes, and when necessary, temporary mechanical circulatory support is needed. In this case, the use of Impella support was entirely appropriate. It was unfortunate that the patient suffered a stroke due to thrombus embolism from the device, but these are the hazards we accept when using mechanical devices to save people's lives. Regarding temporary mechanical circulatory support, it's encouraging to know that patients who present with shock due to takotsubo syndrome tend to have fairly good short-term outcomes when temporary mechanical circulatory support is needed, with up to 95% recovering and surviving to hospital discharge, a number that's far greater than patients presenting with other etiologies for cardiogenic shock. I'd like to finish with a few comments about post-ICU management and the longer-term care in patients with takotsubo syndrome presenting with shock. Firstly, one needs to be on the alert for ventricular arrhythmias. In the first 48 hours or so after presentation, takotsubo patients are at risk for ventricular tachycardia or ventricular fibrillation related to high circulating catecholamine levels. After this, the vast majority of takotsubo patients develop profound repolarization abnormalities on ECG, with a pattern consistent with Welland's pattern and profound QT prolongation, often in excess of 600 milliseconds. This pattern can persist for weeks and can linger much longer than LV recovery. And so it's become my practice to send these patients home with a wearable defibrillator vest because there's a small but not insignificant risk for polymorphic ventricular tachycardia due to torsades in the setting of profound QT prolongation. Also, for those with apical ballooning or profound akinesis on echocardiogram that lingers at the time of hospital discharge, I think it's important to do something to definitively exclude the presence of LV thrombus. This can be a contrast-enhanced echo, a CT with contrast, or even an MRI. If thrombus is present, then a short course of oral anticoagulation may be sensible, although this practice is not based on any strong prospective randomized clinical trial data. Although takotsubo patients typically normalize LV function within days to a week after presentation, some may need up to a month or so. Observational studies suggest that despite recovery and generally good short-term outcomes compared to patients presenting with, say, STEMI, longer-term survival in takotsubo syndrome is not as rosy as you'd think. When looking at age and comorbidity-matched patients, general survival is poorer in patients with takotsubo syndrome and tends to track more closely to the survival curves of patients presenting with acute coronary syndromes. That's interesting to me because Takotsubo syndrome is typically a one-and-done phenomenon, as reoccurrence is fairly rare, occurring in only 5 to 10% of patients. Thus, there's something about the mechanism of Takotsubo syndrome that can have a lasting impact on survival, even when the patient remains free from the disorder moving forward. In terms of long-term management, we really have no prospective controlled trials to guide us as of now. Most patients are discharged on heart failure GDMT of some variety, which seems appropriate, although what to do after LV recovery is anyone's guess. We reviewed 700 cases of Takotsubo syndrome retrospectively at our institution, and in multivariate analysis, the two medications that were associated with the best long-term survival, and we're talking about 5 to 10 years after the index event, were aspirin and beta blockers. I tend to keep my post-recovery patients on both unless there's some contraindication or poorly tolerated. My rationale for this is that mechanistically it tends to make sense, and because of our own retrospective data. But I readily acknowledge that there's no prospective justification for doing this, and not every institution adopts this approach. Well, that's my take on this case. I'm glad to hear that the patient ultimately did well, and I thought the team did an outstanding job with their management. Thank you so much for this opportunity to participate. I hope my comments have added to the teaching points already made on this very interesting case. Thank you.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Diane Masket. I'm an intern in the CardioNerds Academy House Thomas and fourth-year medical student at Rowan Virtua School of Osteopathic Medicine in New Jersey. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.